My name is Dr. Grace Jackson, and I am a psychiatrist currently practicing in north central Arizona. And the title of this presentation is Building a Better Understanding of Antidepressants. So this presentation, now this was working a minute ago. Isn't that funny? You take a break and then nothing wants to be in. It's always the way. Try this again. Okay, so the outline here, we're going to be talking about antidepressants, a little bit about where we are right now, two, how antidepressants, their impact on brain function, three, their impact to brain structure. We're going to be talking a little bit about blood flow to the brain, and then finally talking about the implications of all of this information. So first, antidepressants in perspective. There are 5 major families or classes of medications that are used in psychiatry. And you've heard a lot of the speakers this morning talk about these, but I thought it might be helpful to just reorient you. The 5 major families are antidepressants, antipsychotic medications. These would be things like Haldol, Zyprexa, Risperdal, Abilify. That's probably the most common ad at the moment. Mood stabilizers. This would include anti-seizure medications and lithium. Sedatives, hypnotics, or anti-anxiety medications. These would be medicines like Valium, Librium, Klonopin, Xanax, Ativan. And then finally stimulants, which we usually think of in children. These would be medicines like Ritalin and Adderall. So to put this in perspective, the psychiatric drug sales, or the psychiatric drug as a business in the United States, actually generated $2 billion worth of sales in the year 1990. Fast forwarding to 2011, that industry had become a $43 billion industry. So in 20 years, from $2 billion to $43 billion in sales. So this became a major part of our economy. In terms of the numbers of prescriptions, in the year 2011, and this statistic is taken from IMS Health, which is a company that actually tracks a lot of these pharmacy statistics from pharmacies, antidepressants were actually the #1 prescription in terms of the total number of prescriptions written in the United States, 264 million prescriptions. Now again, I'm just addressing medications as they are being prescribed, not necessarily as they're being taken, because there's also a lot of medication use that goes on the streets where people are taking it from other intended recipients. In terms of what proportion of the American population was interviewed as saying, yes, this year or currently I'm using a psychiatric medication, in the year 2013 it was 25% of our culture taking some form of psychiatric medication. Now this is a point prevalence question, meaning at one moment, if I asked everybody in this room, raise your hand if you're taking one, you don't have to do that. That's a different question, you especially, Bert, but that's a different question than actually saying in the past 10 years, how many people in this room. And I don't know if anyone has that information or those data, because that would be a very interesting question. But antidepressants are the #1 psychiatric medication used, prescribed in the United States of all those psychiatric medications, which is why I'm making this the theme of this presentation today. This is the medication class, or the family of medication that I'm most likely to see when somebody comes to see me for any reason. Close behind are the anti-anxiety medications, especially Xanax. And that's almost equal. So 13% of antidepressants, 11.5% of the population anti-anxiety. ADHD meds, 3.25%. The ADHD medications are rising as more people are being prescribed those into their adult years instead of just childhood use. And antipsychotics at the bottom, 2% of our population. So what actually happened is the year 1988 was very pivotal. In late 1987, December of 87, Prozac was approved by the Food and Drug Administration as a treatment for depression. And it was actually marketed, or the launch of it in terms of active use was immediately, actually 1988. So between 1988 and 2008, there's been a 400% increase in the use of antidepressants in our country. And in these surveys, when you ask of the people using antidepressants, how many people have been taking those for 5 to 10 years? The answer is about a third, 30%. If you then go to that pool of users, and you ask the question, how many have been taking the medicines for 10 or more years, in some studies, the answer is 14%, almost 1 in 6. And as a practicing psychiatrist, I have to say that probably 90% of the patients I see have been on psychiatric medications for 10, 20, 30 or more years. I do not see new users, and I very seldom see people who have not been previously medicated. And I have to say, most of the medications that are being prescribed start with primary care clinicians, pediatricians, OBGYNs, internists, family practitioners. They have created this mess. And the psychiatrists, in my experience, are a lot of us who care about this deeply, are trying to run after this mess and try to fix it. This is a very difficult genie to put back in the bottle. So I want to talk for a moment about what's not in textbooks and what is not in most curriculums, to my knowledge, and certainly is not in the professional continuing medical education curricula, which doctors are responsible for continuing in order to maintain their credentialing and their licensure. So even when patients are initially exposed, like in the very, very short term after starting antidepressants, there are some changes that occur in the brain very rapidly, and these are actually electrical changes. So this picture is actually demonstrating, this is from a paper that was published in 1994, and it actually was talking about the impact of one of the antidepressants, fluoxetine or Prozac, on frontal lobe activity, so the frontal part of the brain. And what the researchers did in this study was to insert probes into the brains of the lab animals and then measured the electrical activity in this part of the brain. And they detected a 50 to 60% drop in frontal activity after just 2 weeks of medication exposure. Now, this concept of disrupting frontal lobe function should be something that many of you in the room would be worried about. And in fact, this has some correlations to what clinicians then see when patients come back to them after starting these medications, when they say, or actually, family members or other observers of the patients may tell the doctor, this person is no longer emotionally alive. They're flattered, they lack their zest for life, or they've become apathetic. So a lot of groups have published some case reports on this, and there's a name for this called an antidepressant apathy syndrome. And there was one quote in this particular paper published in 2005. And this 65-year-old patient who had been placed on Prozac had this to say, I used to become unglued whenever the neighborhood kids would ride their bikes through my lawn. Since I've been taking Prozac, I just don't give a bleep. Tell the little bleep to come on. I tell you, Prozac is great. Now, I was actually going to cuss because I was in the Navy, but I was told by my mom, who's here in the audience, that I can't cuss in public, so I had to edit that. Sorry about that. It's too much frontal lobe function. I didn't take my Prozac today. Okay, so the way this used to be advertised, or this used to be described even in textbooks when I was in my training period, there were these cartoons that were marketed both to physicians and to the American public. Some of you might remember this picture, which was for an antidepressant called Zoloft, which is in the same family of medications as Prozac. And it's actually trying to educate the public and the doctors in terms of what this medication is trying to do. So on the left-hand side of the picture is a nerve cell in the brain, and on the right-hand side is another nerve cell. And if the patient is taking Zoloft, those little circles that you see in between the two cells are filled with a chemical called serotonin. So by taking this antidepressant, there would be more of those bubbles left in between the two cells, and that burst in the chemical is alleged to actually improve a person's emotional functioning. So the theory in the textbooks, certainly in my era of training in the 1990s, and certainly through the marketing to the American public in the 1990s and through the 2000s, is that these medications are actually correcting or repairing some kind of chemical deficiency, some kind of chemical imbalance in the patient's brains. And this would actually help not just depression, but also many other kinds of conditions, many anxiety conditions. Now I want to take a moment here and just talk a little bit about how doctors are usually trained to think about biological organisms. If any of you remember biology in high school, or maybe even junior high school, certainly college, there is a concept called homeostasis. Any of you heard this term? So the idea here is that organisms try to remain stable by keeping things within a certain range of, quote, normal. And so the image for this one is the people mover at an airport. It's just nice and flat and keeps things moving along. In fact, the way biological organisms actually survive in the world is much more like an escalator, that we go up and we go down, and that's exactly how we're designed to survive. This is something called allostasis, which is a term introduced by Peter Sterling and Ayer. Their papers in the 1980s are some of the most important papers in biology, even though they're not taught in medical school. So this concept of homeostasis is really outdated and needs to be replaced by the term allostasis. Now, bear with me here, there's one more step to this. What happens in medicine, not just in psychiatry, but in all specialties, all areas of medical practice, pharmaceuticals can then cause these adaptations to become broken or fixed or stuck, and we call this term allostatic load. In other words, the cumulative negative effects of the adaptations that the body makes in response to drugging. So in fact, what actually occurs over time is that doctors are no longer seeing patients and treating patients for their original conditions. They're chasing the allostatic load, which has been introduced by the treatments themselves. This is a very, very important point, because all of the training of doctors in the United States is based on what drugs do in a period of 4 to 6 weeks. None of the training of doctors, either in medical school or after they complete medical school and residency, addresses this issue, that most of medical practice will be dealing with allostatic load. So again, just to summarize, all prescription medications cause allostatic load, negative adaptations, or adaptations that can be negative. So again, over time, doctors end up chasing the chronic or some of these adverse effects of chronic drug use, rather than the initial conditions for which the drugs have been prescribed. Now I want to take a moment here because I'm going to get a little bit technical in this presentation, because I don't want people to leave here having any doubt about the allostatic load caused by antidepressants. So I have to say something about the brain here. This is a cartoon that is showing the key players or the key residents in the human brain. So we have 100 billion neurons. How they figured this out, somebody really stayed up late counting. So that's the yellow cell in this picture is the neuron. And everything else in this picture around it, except for that pink one, which is an actual blood vessel, a capillary, represents support cells that we call glia. Now there are 100 billion neurons in the brain, 500 billion to 1 trillion glia, or support cells. And almost all of the research through the year 2016 with respect to psychiatric medications is focused on neurons, not glia. So that should tell you we have a problem here. We're ignoring the cells that are 5 to 10-fold more plentiful than the neurons and pretending we know what is going on when we prescribe medications. So these other cells are becoming increasingly important to us. That'll have to be a different lecture. But psychiatric drugs, the use of psychiatric drugs have been built around what do they do to neurons, these less numerous residents of the brain. And when doctors are taught to think about these medications, they're taught to actually think about how the medicines are interacting with specific targets. Now these different targets are either called receptors, docking stations, like a peer or a dock remote, or reuptake pumps, things that are actually on the surfaces of cells to suck chemical back into the cells so it can be used again. So what's important? What happens with antidepressants? We have quite a number of studies in animals that demonstrate the allostatic load. What happens is that antidepressants actually begin changing the targets of the antidepressants. And so this particular picture is showing an electron microscope picture. These are very expensive studies, and not many places in the world perform this kind of research. But what you're actually seeing on the left is a normal cell, and then you're actually seeing the two cells coming across, changes that are occurring in the target of the antidepressants, like Prozac or Zoloft. And so the little black dots that you see on the edge of that cell, and I do have a pointer, I should probably get it out, but those little black dots are actually the target for Prozac and Zoloft. We call that the serotonin reuptake pump or reuptake transporter. It's called the SERT. And those actual transporters begin to move inside the cell, which is what you're seeing on that very final picture. You are actually looking at a brain cell, a neuron, and those little black dots that you see are the targets of Prozac and Zoloft. And they're actually moving away from the surface of the cell into the middle of the cell, and they're becoming more numerous. And so the researchers who did this particular study in animals found a 50 to 70% reduction in the transporter after just 3 weeks of daily Prozac, a 70% reduction. Now, what are the implications of this? Well, that transporter is there to suck serotonin out of the location between the two cells that we call a synapse. So it's recycling serotonin. If you take away the ability to recycle unused serotonin, it's going to have some consequences. It's also the case that more recent research than what was performed 30 years ago demonstrates that those serotonin reuptake transporters also go in the opposite direction, that they also contribute to the release of serotonin. So it's bidirectional. And there's even more research that's been conducted that shows that the release of serotonin is occurring in a lot of other parts of the cell, not just the nerve cell ending. So the picture is much more complicated than what doctors have been told. So what appears to happen is in the 90s and 2000s, patients were kind of sold this picture that if you take these medications, your serotonin gas tank, which is running on empty, will now be filled up and you'll feel much better. But in fact, there is an obscured literature that is not in the textbooks and not in the curriculums or the training programs of doctors that really points in animals, and then we can correlate this in humans, to the fact that the antidepressants begin to create a serotonin deficiency. So this study is from 2010, a group in the Netherlands, and they actually looked at the impact of long-term citalopram or Celexa, and they were studying this in rats. And what they found after 14 days of exposure is that the antidepressant had created a serotonin decrease by 60%. Now, if we look at a more recent study done at Cal State University San Bernardino, this is Amadeo's group. They looked at teenage animals to see if teenagers were also susceptible, and these teenage rats had 10 days of exposure to Paxil and Prozac, and they found something very similar in several regions of the brain, a decrease in the serotonin content by 18 to 20%. And in fact, if you spend time perusing the medical literature, this is not easy research to find, which is probably why it's not emphasized. The drug companies really did not want this emphasized per se. But numerous groups, starting in the 1990s, and even as recently as we saw that group at San Bernardino, have discovered something very consistent, that as animals are maintained on these serotonin antidepressants, the actual production of serotonin in the brain begins to decline. Now, these findings are consistent with what happens in humans who've been exposed to antidepressants, and the best way we can try to correlate this story that's happening in animals is to see what happens to humans who've been on these drugs, who are then subjected to an experimental paradigm, which is called a monoamine depletion study. That's when their levels of different chemicals in the brain are briefly manipulated by diet, and we can see if certain symptoms seem to return. And this is a very large literature, dozens of studies. Delgado and many other researchers, if you're interested in this, suggest that just what we see happening in the animals is something that happens to humans. So when humans then suffer any further drop, they already have a vulnerability to relapse or to recurrence of whatever their problem may be. So to summarize, the brain functions change as the levels of essential chemicals in the brain actually are going through fluctuations, and in this particular example, decrease. So we think this is probably one of the ways in which the brains of patients become more sensitive to relapse or even to chronic symptoms. I'm going to move on now to actually talk about the structure of the brain and how brain structure changes under the impact of medications. There really have not been many animal studies that have been published, at least, on this topic. But one of the most important was published at Thomas Jefferson University. This was Kalia's group in the year 2000. They published this paper. And they were actually trying to look at the structural effects of known serotonin toxins. So they looked at a street drug called ecstasy, and they looked at several other chemicals that impact the serotonin system, including Prozac and Zoloft. And what they found in these animals after just 4 days were significant anatomic changes. Now what you're seeing in the picture on the right is a very special kind of study. This is called dark field microscopy, so it's not the kind of study that everyone would be doing. And what you're actually seeing in that picture is under a microscope what the serotonin fibers look like. What do the neurons look like after the animals have been exposed to the antidepressants? And they don't look normal. They get truncated, they're shorter, they get thicker, they get strange little bulbs or varicosities, and these actually are abnormal.
You said serotonin, you mean the neuron?
The neuron on the right, we're looking at serotonin fibers. We're looking at serotonin neurons.
Serotonin neuron.
Serotonin neurons, right. So in the brain, we have many chemicals.
Right.
And neurons can be identified according to their main chemical, what they're kind of specialized. So just like you'd have an architect and an engineer and a lawyer, you would have neurons that are specialized in serotonin manufacture, and another group of neurons that just make dopamine, and another group that make GABA. They're specialized. And sometimes they're promiscuous. Sometimes they release more than one thing. It's kind of nasty in the brain, it really is. But for the most part, I don't want to get into the romance of the brain, but for the most part, they're specialized in terms of where they're located and what they do. So these are serotonin cells, that's their specialty. So they're not normal. And why is this important? Because an interesting group at New York University was looking at serotonin fibers in the brains of humans. And they looked at humans who had had various kinds of degenerative conditions, different kinds of diseases, like Parkinson's disease, Lewy body dementia, which Robin Williams, we just found out that's really what he had. It wasn't just Parkinson's, it was more than Parkinson's, it was Lewy body, and frontal lobe dementia. And so these pictures now are going to show you what a human brain looks like when the serotonin fibers begin to fall apart. What we get is neurodegeneration. And so they found the similarity. Serotonin fibers were reduced in density, fewer of them. They were twisted and swollen, edematous. They were shorter, they were bloated. The same kinds of abnormalities that were seen in those lab animals after Prozac and Zoloft were seen in these patients. This is actually demonstrating what does a damaged serotonin network look like in a human, and what is the implication. And interestingly, 6 of these 9 patients in this study had received antidepressants. So we don't fully know the picture in them either, if the antidepressants had caused some of these changes or not. So where are we? Another part of talking about structure of the brain is this gentleman right here, Santiago Ramon y Cajal, is considered the father of neuroscience. He lived between 1852 and 1934. And basically it's his theory that we're stuck with, that when we understand the brain, we really focus on the study of neurons. Well, he had this thought that after birth, we don't get any more neurons. That's it. You're out of luck. That's all you get. What happened from 1965 forward is that many different groups of researchers began to notice something to challenge Ramon y Cajal's theory. And this is called the Neurogenesis Theory, that new neurons can be found in certain regions of the mammalian brain. Altman and Doss was a group, they found this in a rat, and then another group in '77. Then this was happening, this was found in canaries, and then finally in 1998, several groups thought they were identifying new neurons in the human brain. Well, this was tremendously exciting, as you can imagine. This is like, stop the presses, you know? Well, we've got new news here. We do actually have new neurons. And I like good cartoons, so this is what it would feel like if you were a snowman getting a new neuron. Look, stem cells. Stem cells are considered like a generic blank template. It can become anything. And so these snowmen are very excited about the snow. And so what happened in response to these discoveries was a new theory of how antidepressants might be helpful to patients. So Jacobs, Van Praag, and Gage, they said, listen, we found something here. The brain does create new cells, and we think that where these new cells are going has a real important implication for human patients. This may be a solution for depression. So the theory was born that one reason the antidepressants are so helpful to patients is because they actually help the brain have new neurons. It puts new cells into the parts of the brain that are most impacted by stress. And this is called the Neurogenesis Theory of antidepressant action. So what you see in this picture is a human brain on the left, a cartoon of one, and on the right, a cartoon of a rat brain. And the yellow strip, the yellow stripe that you see is one of the sections where new cells have been found in animals more than in humans. And the blue stripe is another section. The blue stripe is called the hippocampus. No, that's not where African animals go to college. And the yellow stripe is actually the lateral ventricle. This is one section of the brain that holds fluid. It's supposed to be there. And there's an area around near the lateral ventricle called the subventricular zone, and that's an area that has new cell growth. So if you go into the animal studies, this theory is really outdated even by now. Number one, the problem is in the animals that many of the new cells that have been identified, that finding does not occur in adult animals. It's only in the young animals. Problem number two is that the new neurons, when they have been found in young animals, do not survive, so they don't last very long. Number three is even when there are new neurons that are located in some of these animal studies, they don't integrate in an area that is actually helpful. So if I just drove up to your house and dumped off 200 pounds of bricks and said, there's your new patio, and drove away, you'd probably say, come back. That didn't do anything, unless you just wanted bricks. But to just put new neurons into any animal, really is not meaningful if they don't survive and if they're in the wrong place, and if they don't integrate. And even more important, number four, very few studies, but there's at least one important study that has asked the other part of the question. If you're delivering new neurons, what's happening to the old ones? And there's one study that looked at both of these questions and found that the antidepressants are killing cells in the hippocampus. So you can't get new cells without a trade-off, and if you're killing some of the old cells, we should be worried about that. That's the hippocampus is a region of the temporal lobe where we are thought to one of the most important structures in the brain, maybe not the only one, but very important in terms of learning and memory. So to lose cells in this area is really one of the areas that researchers in dementia, most worry about. And this is one of the areas of the brain that's most severely impacted by Alzheimer's disease. So what about human studies? We don't have the luxury that I know of actually killing patients who've had antidepressants. Somebody somewhere may be doing it, so I have to put that in parentheses. Nobody that we know of who's killing patients after they've had antidepressants and then looking at the brain intentionally. We have brain scan studies to look at what happens to this part of the brain after patients have been on treatments. And then we have some autopsy studies, but we really don't have much. And so the question is this theory of antidepressants causing new growth in this memory part of the brain? Is this something that we really should be excited about? And if it isn't, what should we do? So in a paper in 2004, this was a National Institute of Mental Health study, looked at 22 depressed outpatients, ages 18 to 60. And all of these patients were prescribed antidepressants. And they looked at the size of the hippocampus, the memory zone of the brain, before and after the medications. And what they found is they were looking at the hippocampus as the volume of this section of the brain as a percent of the whole brain. And they found that pre-treatment, they found that the percentage was 2.79% on the left. After the exposure to the antidepressants, the size was 2.68%. It was a decrease. Now, these numbers may not appear large, but the point here is to demonstrate the trend and to correlate this to the theory that we're going to be dumping in all these new cells, and those are going to repair the brain that has been injured by stress. And this is how antidepressants are helping people recover from depression or from anxiety. So they didn't really see significant changes on the right side, but they did find some changes on the left side in this study, and they weren't in the direction that the doctors would necessarily be thinking or anticipating. Another study, this one was from Duke University, published in 2014. They looked at 92 depressed individuals and 70 people who were never depressed. Don't know how you find those folks, but there you go. Ages 60 and above, all of the depressed folks had received antidepressants, and they looked again at changes in the size, the volume of this part of the brain on brain scans, according to how people were doing. And what they found was, quote, no significant increase in the hippocampus in any group. In fact, 80% had hippocampus shrinkage after the medicines. So it's kind of an unusual study because they found that the remitted, the never depressed, actually the brain region seemed to get a little bit bigger, and the remitted and non-remitted both had a decrease in the brain size, and the people who relapsed actually stayed about the same. So again, it's just more evidence to suggest that, again, the theory is give someone an antidepressant, add more neurons to the memory zone of the brain, improve depression. And these studies are showing quite the opposite. Finally, what about giving these medications to people who already have dementia, or people whom we think have a disease called Alzheimer's disease, where neurons in the hippocampus and the entorhinal cortex begin to die out, and then those connections begin to affect other parts of the brain, and before you know it, you have a very severe neurodegenerative condition in multiple regions of the brain. This particular study from South Korea looked at the effects of Lexapro in patients who are already thought to have Alzheimer's disease. So this is a 1-year study, and they looked at 74 patients between the ages of 40 to 90. And the important part about this study is these were not depressed patients. They were looking specifically at what happens if we give these patients an antidepressant and try to revive or resuscitate the hippocampus. And they looked at before and after brain scans, and they took the group and they said, half of you are going to get the antidepressant, and the rest of you are going to get a placebo, a sugar pill, and we're going to see if one of you is showing a better effect in terms of the hippocampus. And what they found is that the antidepressant did not prevent the progression of brain shrinkage. So in the Lexapro group, the antidepressant group, the hippocampus became smaller by 7.63%. The whole brain volume was shrinking by 3.27%, which was more shrinkage, more atrophy than in the placebo group. So what they found is that this medication is not doing what we had hoped. It is not resuscitating the hippocampus. And finally, Lucasen's group at the University of Amsterdam has probably the only postmortem study that I've been able to identify in Medline that looks at the size of the hippocampus in people who have been taking antidepressants versus people who have completely avoided those exposures, or this had a control group of people who had taken steroids. Now, one of the reasons researchers have been interested in the hippocampus is because they think that this is an area where stress leaves its biggest imprint in the human brain. So it makes sense to them to say, let's see if the hippocampus demonstrates damage in response to stress, and then we hope the antidepressants correct those negative effects of stress. And so what they looked at here was a control group of people not taking antidepressants or steroids, but another group of patients who had taken steroids, to actually quiet down their airways for lung disease, and look at the hippocampus. And what they found is that they looked at a number of findings. Whoops, I think I blew that, didn't I? They said despite the use of the antidepressants, they found that the death rate, now they're looking at the death of cells in this part of the brain, The depressed patients had more cell death in terms of the severity of it and in terms of the areas of the hippocampus than in the other two groups. So there was, in 67% of these patients had been exposed to antidepressants, and they had far more extensive cell death in this part of the brain. Now we could say that was just there because of the depression, but it is concerning when we combine this with some of the animal research to at least ask the question, hold it, how much of this may also have been there because of the antidepressants? So finally, Luke Hessen's group did an autopsy study of elderly depressed patients to look at the question of what about neurogenesis in a human brain. And they were comparing the numbers of new cells at autopsy. 5 of these patients in this study had taken antidepressants, 2 had taken lithium and or other medicines for manic symptoms, and 3 had not taken psychiatric medicines at all. And what they found in this study is that the total number of proliferating cells was lower in the patients exposed to those medicines than in the control group. So they could not find any evidence that there was a normalization of new cell growth in the patients, even though they had been exposed to the medications. So what we're seeing is a theory that sounds very hopeful and very exciting, that you give people antidepressants, you start fixing their Alzheimer's disease brain, you start reversing the negative anatomic impacts of stress. And in fact, the studies are not holding up, neither in animals nor in human beings. And finally, this is really important because of what you can actually see in real clinical practice. Now, we hear a lot about Alzheimer's disease because it has a whole association dedicated to research and the marketing of medications for its treatment. But vascular dementia simply means the dementia, the symptoms of dementia, memory problems, planning problems, organizing problems that are due to impairments of blood flow. So the brain itself is not getting appropriate blood. And when doctors think about blood flow in the brain, they think about how this becomes impaired. And so one way that people experience difficulties with blood flow is through something called a stroke. And we can think about that like a heart attack. This is like a brain attack. So something interrupts blood flow, and it can either be some blockage in the arteries or in the vessels that feed the brain, and that's called ischemic, meaning there's a decrease in oxygen. Or it can be a bleed, so it can be hemorrhagic. And when the brain bleeds, it means that the blood is leaking out of the blood vessel, and the blood is supposed to be flowing through that vessel so it can get to the next target and feed all the tissue. So those are the 2 major kinds of strokes. But some people don't suffer a major stroke, they suffer mini strokes, which we call transient ischemic attacks, or TIAs. But, and this is a big important thing, some people experience silent strokes, silent mini strokes, which we call silent ischemia. So they don't know that their brain is not getting perfect blood flow, but they're just happening completely quietly. It's totally off the radar. There is emerging evidence for antidepressants increasing the risk of strokes. This was a meta-analysis published in 2014. Shin's group looked at 13 studies. This particular meta-analysis was only looking at the serotonin reuptake inhibitors like Prozac and Zoloft. They found all the kinds of strokes were increased in risk. One of the most important studies is looking at what about people who've already had a stroke, because one of the guidances now, or one of the areas of enthusiasm in the United States, is to have doctors who are now meeting patients who have had a stroke, many of whom become depressed either because of the physical limitations associated with the stroke and its recovery, or because of chemical changes in the brain after the stroke. And so this concept of how do you help people with post-stroke depression has gained a great deal of attention and enthusiasm in the neurology crowd. And they very much would like doctors to be treating stroke survivors with antidepressants. So a group in Taiwan did research that is pertinent to this question. Now in this study, they looked at the recurrent stroke risk in a 10-year study. So what they did is identify people in their country who had had a stroke and then follow them forward until the time of a second or more strokes. So it's a study of recurrent strokes. And they wanted to identify, is there anything that's different in these 2 groups according to their medication exposures? So some of the patients were already on antidepressants at the time of the first stroke, and they stayed on those drugs. We call those continuing users. And some of these patients were not on antidepressants when they had their first stroke, but they were placed on them sometime afterwards. So these were new users. And what did they find in Taiwan? They found that continuing users had a 23% increased risk of another stroke. And if you were a new user, you had a 57% increased risk of another stroke. And when they identified the kinds of treatments that the patients were receiving, none of the antidepressant classes were safe. This was something that was happening in the serotonin reuptake inhibitors, the older antidepressants, and even the others. What would be an other type? That would be like Wellbutrin or mirtazapine, Remeron, something other than Prozac, Zoloft, that family. So there was an increased risk of recurrent stroke. Okay. Now this picture is really the story of what I deal with in my practice. So my practice is mostly geriatric, and most people who come to see me have been prescribed psychiatric medications, usually Cymbalta for fibromyalgia. Usually, anybody here see that? So basically people have been on these medicines for 10, 20, 30 years. And this is a picture which is an MRI scan. And when you look at pictures of the brain, I'll orient you here. Pretend there's a bird that's flying over the top of the head looking down on it. That's what these first two images are showing. And that third picture is looking at a brain as though you're coming from the front to the back. And so this is what the brain looks like on a magnetic resonance imaging or MRI scan. And so the outside is, I think about the brain like a coconut. The outside, our shell, is the skull. And inside we've got white coconut meat, which we actually call the cortical tissue. And then we have fluid in the middle, which is like coconut milk. And we have to have right balance. Ty left, because Ty was talking about some of these changes yesterday. So the coconut milk is the ventricles, and then the tissue around it's the coconut meat, and the shell on the outside. And that's what you're seeing in this picture. So the dark space that you see in the very middle is fluid-filled space. That's what, in this picture, we call the lateral ventricles. That fluid is supposed to be there. And everything around it that you're seeing is the coconut meat. That's brain tissue. And the very outside is the coconut shell of the skull. The white patches that you're seeing are places where the blood flow has been impacted. So this is something that we call WMHs on these scans. They're called white matter hyperintensities. They used to be called UBOs, unidentified bright objects, but I guess we started identifying them, so now they're not UBOs. I love that. So the UFOs are gone, but the WMHs have come. So there is a term for this that the more extensive this becomes, we call this leukoariosis. So this is an example of silent brain attacks. So what happens with antidepressants? This is an important study, was part of the cardiovascular health study. Patients were drawn from California, North Carolina, Maryland, and Pennsylvania. And in this study, the researchers took a subset of the patients and they said, hey, you guys, would you agree to have your brain scanned? And they threw out anybody who was already taking an antidepressant. They said, you can go. We're just going to take people into this study, and we want to actually compare MRI scans at 2 points in time going forward. We're going to see a before and an after, and then we're going to see what happens to you folks in this prospective study. And they're going to examine the brain in terms of what happens going forward. What they found is that those white patches that I showed you in that previous picture, there was a worsening of those white patches in 27% of the patients not using antidepressants. But there was a worsening of those white patches in 36% of the patients who were using the antidepressants. So the antidepressants seemed to have some kind of impact on what was happening to the blood flow in the brain. In 2012, Geerlings et al., they published a paper. This was actually New York City residents. So they went and they found 630 patients, 65 years of age and older, without dementia. And they followed these patients between 2005 and 2007. And they were evaluating these patients for depression, antidepressant use, and then what did their brains look like. So the mean age of this group was older, it was 80, and they had 125 depressed patients, 53 of whom were taking antidepressants. And so they're going to look now at what the brains of these patients look like according to depression and according to antidepressant use. So 8% of the entire group of 630 patients used antidepressants during this study. And what they found is that antidepressant use, but not depression, was associated with a 9% smaller hippocampus and 33% more white matter hyperintensities. And again, they looked very carefully to say, is this the depression or is this the treatment? And they said that seems to be the antidepressants. So the same research group goes back to work, this time in the Netherlands. This is Roel et al. They looked at 594 patients in the Netherlands. This time, these were patients also with known symptoms or features of vascular disease. Previous histories of heart attacks, aortic aneurysms, strokes, peripheral vascular disease. This time it's a younger age group. Mean age was 58, and the age range was between 48 and 68. And they followed these people over a 4-year period of time. And at baseline, 5% had used antidepressants. And what they found was that antidepressant use was associated with a greater volume of these white matter hyperintensities. And both the serotonin reuptake inhibitors and the older antidepressants were associated with deep subcortical white matter hyperintensities. Then they asked the question, what happens as people use these going forward? And they found that antidepressant use over the next 4 years was associated with an increase in these white matter hyperintensities around the ventricles. Then they controlled for depression itself, and they found that depression was not associated with the white matter hyperintensities. And finally, the University of Pittsburgh just did one of these studies. They looked at patients 60 years of age and above, and this was just a 12-week study, and they looked at Lexapro, Cymbalta, or Effexor, and again, baseline and follow-up scans. And what they found is that all the patients experienced an increase in white matter hyperintensities. So we have this very interesting, consistent finding now. In this particular study, they found more of this in the patients who did not remit. So there is a finding not just of antidepressants that seem to be associated with this change in the brain or the progression, but also the symptoms of depression are less likely to respond to treatment. So how many of you have heard of this theory? It's called the vascular depression theory. There's a group of researchers who've been looking at this, and they say, you know, we think in older people especially, you can't impair the blood flow to the brain and get a good outcome. And it's not just cognitive. There are also emotional mood effects from this. So I'm going to show you what it looks like in Arizona. This is the brain of one of my patients, a 7-year-old male who'd been on Cymbalta for 8 years. And this is what his periventricular region looks like. Again, that white stripe that you see by the ventricles is what we're talking about. That's what's been found in these different research studies. This is the brain of one of my 70-year-old patients. This is a female who had taken antidepressants with or without Valium for 18 years. And you're seeing, what are you seeing? You're seeing silent ischemia. So you're seeing the progression, or you're seeing these vascular changes. This is a 70-year-old female who had been on various antidepressants for 50 years. So she has more of these changes. So she also has pretty significant frontal lobe shrinkage. So this is more of a, this particular patient can barely function without a notebook and has been in speech therapy, cognitive therapy for 6 months. This patient could barely find my office. She's 85 years old. She'd come on the wrong day. She'd get lost driving. And I couldn't really convince her or her husband how important it was to gradually decrease her antidepressants, and then they finally went away. Sadly, she had some of the worst dementia I've ever seen, and she had been on antidepressants for about a decade back in the 1970s, and then her primary care doctor put her on Lexapro with Wellbutrin for the past 3 years, and this is very, very progressive, very extensive leukoariosis. So what are the implications? Well, the chickens are coming home to roost. If you're in psychiatry, we get to now pick up the broken pieces of what the primary care folks are doing to us. If I sound a little bit angry or bitter about this, I really am, because they have no consciousness of what they have created. And it's not the psychiatrists who are starting most of the people on these medicines, but the psychiatrists, if they understand and pay attention to what's going on, are unfortunately the doctors who now have the responsibility for mopping up this mess. So the elephant in the room is that all classes of psychiatric medication are associated with increased risks and increased rates of dementia. Our medical system doesn't have the slightest response to this at the moment, because there's no awareness and no discussion of this going on. When we talk about dementia, dementia is simply a wastebasket term for a syndrome. It means memory may be affected or not, but usually that's what people most associate with dementia. It can also include things like the impairment of language, word-finding abilities, being able to read or write or express oneself. It can mean the inability to carry out certain motor functions. We call this apraxia. That can include things like dressing oneself, figuring out how to manipulate an eating utensil, how to use a remote control for television, or how to use your microwave. Agnosia, which means a failure to recognize things. This can include faces, so not being able to recognize the people that you love or people in your life. And then executive functioning deficits. That would be the inability to do the things that are most uniquely human. So planning, abstracting, communicating, figuring out how to drive somewhere, go to the store, do your shopping, come home and cook your food. All of these are executive functioning examples.
Grace,
sure.
Are you including the tricyclics?
Yes. So the one that we hear the most about in this country is Alzheimer's disease, and that's supposed to be the leading cause of dementia. And I have to say, we really don't have meaningful statistics on how many people in the United States really are suffering from dementia, because Medicare doesn't pay doctors if they put down dementia as a diagnosis, either as a leading diagnosis. I think sometimes I've put dementia on a billing sheet, a claim, and it'll get kicked out by CMS, like try again, put something else down. So what this means is that our research literature in this country is probably pretty fraudulent when it comes to actually tracking the rates, because if a doctor can't record the thing they're really treating a patient for, they have to put down some other diagnostic label. And so when research is conducted in this country, a lot of the epidemiological research is based on going into a database and pulling up how many people in this area of the country had this billing code. It's not based on a chart review. If somebody would go into a doctor's office and read charts, they would capture the fact, geez, Dr. Jackson, 90% of your patients are having cognitive problems. But that's not what gets reported, in the journals. So Alzheimer's disease is supposed to be the #1 cause. We can't diagnose Alzheimer's disease yet based on a living person. We don't have reliable tests in the blood or the urine or spinal fluid. So it's based on autopsy studies. So it's a guess. What I think is most common is vascular disease, vascular dementia. But that's not sexy, it doesn't get research dollars, and there are no medicines for it. So most people have multiple causes of dementia, and not just one type of disorder or condition that's causing the symptoms. So we look at dementia by what is the brain looking like under a microscope, and what do we think is causing it. And then we look at the location. Is it located in the outside part of the brain? I think about the brain, or I describe it to my patients like a Tootsie Roll lollipop. So the outside part is the cortex, that's the candy coating. The Tootsie Roll center is the subcortex, and the brainstem is the lollipop. And eventually, all dementias, in my experience or my research, begin to impact everything. It's all connected, and you really can't say a person has a problem just in this part of the brain or just in that part of the brain. So to wrap up, antidepressants in perspective, it's at least 13% of our population and growing. The more fibromyalgia gets treated and identified in our country. The antidepressants sure are doing a heck of a job at disrupting brain function in lots of ways. I'm only talking here briefly. The antidepressants do quite a job on dopamine, so there are a lot of patients who've been chronically medicated with antidepressants who now have dyskinesias. A lot of my Cymbalta patients have quite a bit of hand dyskinesia. A lot of my Wellbutrin patients, that's the first thing I look for is their thumb flicking. So there are a lot of dopamine effects. I think the tardive dyskinesia or the dyskinesia with antidepressants is surpassing or may surpass antipsychotics because so many more patients are on these medicines. So we looked at some of the animal evidence to look at how these medicines are actually not repairing chemical synthesis, but actually impairing the brain's production of very necessary chemicals. And then we looked at structure, that there is some evidence in animals, and certainly brain scans that are suggesting the antidepressants are harmful to the neurons of the brain and not actually contributing to new cell growth in the hippocampus. We see shrinkage in the hippocampus, which can mean a lot of things, but it can also be reflecting damage to that part of the brain by these medications. And then finally, what I see more than anything is this silent ischemia, these white matter hyperintensities in my antidepressant patients, almost all of them. So we have a real silent epidemic of vascular dementia going on that nobody's talking about in this country. And even without that silent ischemia, there's also an increased risk of strokes, and some studies suggest an increased risk of recurrent strokes with antidepressants. And the implications are basically an epidemic of multifactorial dementia. So it's very frustrating. You know, I've been talking about these things my whole career, but the medical profession, even my local community, won't respond, you know, to how serious this is. So this is really what's going on with our antidepressant picture, and I think that's it.
Questions?
Sure, good.
Grace, it was a wonderful presentation. Thank you very much. I just wanted to ask the question, you know, in working with people coming off drugs, let's say they've been on for 10, 20 years, what are the implications of this research? Will they be left in a damaged state? Is there something which is corrective? Have you found any effects of stopping the drugs and then an improvement? Do the brain structures return or not?
Well, this is a great question. I think, well, the question is, you know, that everybody here, okay, so the question is, can people get better? And how irreversible might some of these changes be? The sad thing is because we don't have an acknowledgement that this is a real phenomenon. We don't have, therefore, a study to explicitly address that question, and we should have these studies. I can say that I worked for 1 year as the medical director of the local community hospital. It was kind of a freak thing I fell into. And so for 1 year, I had the wonderful opportunity to work in a predominantly geriatric unit and to meet many patients who had been wrongly medicated, over-medicated, mismedicated, and for a year work with an extremely talented team of physical therapists, speech therapists for the cognitive therapy, and occupational therapy. And we had many people demonstrate significant improvements in their emotional state, in their cognitive state, just in 10 to 14 days of work. So we had some wonderful, wonderful outcomes. Of course, the hospital was not invested in this. Nobody in the community was invested in this, and eventually our hospital got put under another hospital's management, so we lost this opportunity to continue the work. So I can speak experientially that helping, especially older folks, but I'm sure younger folks as well, helping them clean up that burden, that toxic allostatic load, really is something people respond to. So clinically, experientially, I know this can be done and people can benefit. We don't have yet any research in the United States that I'm aware of that is specifically looking at this from an academic research protocol and then saying, hey, let's go back and rescan these folks and let's see how those changes, you know, may be improving. Because many of those changes, they're not static. You know, we know from multiple sclerosis, we know from lupus, we know from a number of vasculitis conditions that just when you see white matter hyperintensities, they're not all static. And even if they're there, you can still be improving the functioning of the brain by taking the other unaffected areas of the brain tissue and helping them build new connections and new bridges. So this is a totally, totally unexplained, unexplored, you know, area of medical practice, and the questions are important, but nobody's really looking at it yet. So experientially, I've seen people improve. Do we have the actual brain scan evidence yet to go with it? Not yet.
Excellent talk. This is really wonderful. What can you tell us about glial activation? You know, in pain management, we're aware of that in relation to opioid-induced hyperalgesia. Is there any data in relation to antidepressants or benzodiazepines in that regard?
Well, you know, I could probably, I will answer that question. I could go through each class of psychiatric medication and explain how every single class is actually contributing to dementia in some way. I think the problem with some of the research is that each independent group of researchers will take one question, like that microglial question. And there is some research with antidepressants that seems to indicate there may be some changes that are now called an anti-inflammatory hypothesis of antidepressant functioning. So the theory now is that if a patient has any kind of inflammatory disease or illness, put in the antidepressants because it'll fix the inflammatory disease. Well, you're seeing the outcome of antidepressants: hippocampus shrinkage, damage to the serotonin network, partial deficiencies of serotonin and dopamine, and impaired blood flow. So it's silly for us to take our eye off the ball and say, look, in this area of research, we've seen that the glial cells are now less inflamed, or we've decreased an inflammatory response, when we're missing the bigger picture. The bigger picture is people are dying on these drugs, and we've got an epidemic of vascular dementia. And there is some use. I use antidepressants in what I call a responsible way. I try to identify the medical conditions that a patient may have. Palliative care is a different story. You know, by the time somebody's end stage anything, I think most people do what's humanistically correct and say what's going to help with sleep or anxiety or whatever. When we're talking about what's happening to our culture, primary care doctors and nurses are putting people on these medicines, or heck, I mean, it's happening at age 1 or younger, and keeping them on it for 30, 40, 50, 60 years. So I think there's some interesting research on the glia that are coming out, and that may be important in terms of some kinds of neurological conditions. So I've got a woman that I prescribe Wellbutrin to, so her monoclonal gammopathy won't progress to multiple myeloma. So I'm very aware of like the bone marrow effects of medicines, or the neurological effects, the immune system effects, and I use the psychiatric medicines for those medical conditions, not for a psychiatric reason. But so for neurological conditions, there are some interesting questions. It's a great question. We don't have the research yet on glial cells.
Two things. One is my brother's a primary care physician.
Did I just insult him badly?
Yeah.
I apologize to your brother.
However,
He's a good one.
It's just that I want to put one layer in there, which I think everybody here probably already knows, and I'm not saying anything new. Because as a psychologist, I get folks coming in all the time saying, my primary care doc won't write this for me, do you have a good psychiatrist? And that's not always easy to find, whatever that is, okay? But it's the pharmaceutical industry with those ads that were illegal years ago to have on TV. So my brother gets calls, or people come in with a list of medications that you're supposed to ask your physician about. And he Xeroxes pages out of Bert Karen's book because, of course, we educated him 20 years ago about what we're doing here. And so he actually gives them excerpts from Bert's book. Sorry, Bert, about the royalty issue there, but Bert Karen's book, and tries to do the psychoeducation. He also doesn't have enough mental health professionals that know what we know to refer to. So there's a desert out there, but this whole big ad campaign thing, we all know, is a nightmare and it's evil. And we really need to do something there, because the primary care docs are getting caught in the middle. And people are just calling and saying, I need a refill, and they don't want to do the copay to come in and be with a real human being to work on issues in a healthy way. The other one that's really quick to Don's question is touch, and I'm not saying therapist to client touch, but touch within the family and music are very, very helpful in brain plasticity from work I've done for 30 years with brain injury. So take that back to your communities. Any way you can get, whether it's petting your cat or hugs, okay? And music of all sorts really, really help in bringing back a person from the ravages that you're speaking of.
No banjo, though, Grace.
No banjo.
Banjo doesn't count.
Banjo doesn't work. No, it's an inside joke, but I appreciate that.
We have a question over here, Grace.
Well, that was actually sort of a fitting segue into the question I had about neurogenesis. And you said, use the metaphor of dropping off a pile of bricks. So I'm wondering, are neurons that develop after birth, are they useful in any way?
This is a great paper that was just published last year. This is Dennis's group, DENNIS. I didn't have time to finish typing up all the references for this lecture, so I'll have to make them available to the ISEPP website. But Dennis's group, this is in Australia, just published a very critical paper last year where they went through some autopsy studies, large age range, and I think the oldest person was probably in their mid-50s, and they were specifically trying to analyze the brain tissue, all humans, right? And they're looking at the question of how much neurogenesis can we capture in this entire population study. And what they found was minimal. Really, there's nothing after age 2. So they thought they had just done the slam dunk, that Santiago Ramon y Cajal is correct, and that maybe you were right. And now we think, so the question is, how much do adults make new neurons at all, and how significant is it if they're even there? One research group had found 700 a day. Well, if we're talking about millions of neurons in a location, can you even find those 700? So it's much more the case, just what you just said. Let's not talk about new cells, because that has to have an implication of if we just suddenly start cramming new cells in. There are two questions there. What's going to happen to where they're landing? We have to be killing some cells to put those in. Or secondarily, what's going to turn it off? Because uncontrolled cell growth we call cancer. So people haven't looked at how you turn it off once you turn it on. So exercise in all the animals is associated with neurogenesis. In animal studies that have looked at the antidepressant impact combined with exercise, you know what they find? The antidepressant counteracts the benefit of the exercise on the neurogenesis. So those research folks say, wow, that was too bad. I guess we can't give the Prozac and the running wheel to the gerbil or to the rat and get as good an outcome. So the plasticity research, like Jeannie says, you know, the importance of human touch, the importance of music, somatosensory integration. When we talk about yoga, we talk about deep tissue work, we talk about any different way of reaching a person. All of that contact work is how we try to just reach any part of the human that may have some kind of somatic thing going on. You know, it's all a seamless web, you know, in terms of how we're put together. So, you know, back to Ramon y Cajal and Golgi, the two heroes are the huge giants in 20th century neuroscience were Ramon y Cajal in Spain and Camillo Golgi in Padua, Italy. And Golgi said the brain can't be dissected. It's just a network, it's a net. And Ramon y Cajal said you got to look at the individual neurons, they're doing all the work. Looks like Golgi's going to win this one. You know, it is a seamless net, especially as we study something called volume transmission. So this concept that the neurons fire, and it's each firing that releases chemicals, really looks to be probably a much less important thing than the fact that our cells are talking to each other all the time in lots of different ways. And volume transmission is probably one of the ways that these antidepressants how they contribute to that eventual lowering of important chemicals, because it's all leaking out of the cells in a lot of different ways. We need to be far more respectful of how our Creator designed us, and not so cavalier about the fact that just because we can make a chemical means that we should do it, or that just because we can make something, it becomes something we should prescribe to humans.
Wonderful presentation, thanks so much. Just a question about nutritional support for the healing when withdrawing people off of the antidepressants. Have you had experience using some of the serotonin precursors, the 5-HTP, or lion's mane, which is a mushroom that's...
Gee, I don't know about that one. I try to learn from everyone. So when I have a patient come in, or I have somebody say, hey, could we try this, or I read about this, my first question always is what might the unanticipated consequences then become of that next thing, and go research those very carefully. But I am always curious and always learning, you know, and always ready to say, geez, teach me something that I don't know. Like the question about the glial cells, you know, we don't know. So, you know, there's a lot with nutrition. Yes, I make use of a lot of those attempts. Valerian, passion flower, chamomile, what's the other one on that list? Hops. There's like all different kinds of combinations for sleep. 5-HTP, 5-HT, it's very, very curious because we don't know enough about those white matter hyperintensities, and there are some concerns about serotonin contributing to vasospasm or vasoconstriction. We probably don't know enough about 5-HTP and 5-HT in terms of those white matter hyperintensities. But no, a lot of it is still being investigated, still being researched. I think it's very important, and especially when you find something that works for a person and say, wow, you tell me what works. That's really important research.
Grace, you want to do a couple more questions, and then we have to stop.
You bet, we want break.
I have a question. If somebody receives an antidepressant from a family practice or general practitioner, they're usually on the usual formulary of they're on a statin, they're on 2 or 3 antihypertensive medications, and they're on 2 or 3 anti-diabetic medications. So I'm wondering if part of this isn't correlation and not causation.
Well, if that is the case, these groups have carefully controlled. So there are a lot of the research, that looks at propensity scores, and they will control for all those other conditions, and also try to control in terms of what medicines are. So these are all controlled for those factors. It's not that they didn't consider those factors. If all I can say is, if you take 2 groups of people who have the similar predispositions in terms of disease risks and similar medications for those pre-existing diseases, and you give half of the group antidepressants and the other group don't get it, and then you get these results, you have to go with what the results are. So, it's certainly nothing that we are certainly not seeing a theme that says, wow, it's just 1 or 2 studies, that are showing this. It's becoming a consistent trend. So, I guess in the presence of some pre-existing problem, the answer is not something that enhances the problem. The answer is, hey, let's hold it. It's better to do nothing than to introduce, more disease.
Yes, I wanted to ask, well, first I want to thank you very much for pulling together all of this research. I mean, it's amazing that it's all in one place. And my question is there some way that you can share the slideshow? So I was trying to take notes and
sure. Well,
a website or
Well, I think perhaps what I would do is try to add some, commentary to the slides, so it's not just the blank slides, and perhaps get this to the ISEPP website, or even Jim, I think, has volunteered to make this available on his website. So maybe we can try to do that. Thank you.
Is there a book out there maybe that has talked about dementia and psychiatric medications that you might refer to?
I don't know of any. I did write a book. That was a nice introduction. I wrote a book on dementia, 7 years ago, but I haven't had time to really go back and to revise that yet in terms of how much more research there is. In some ways, there's quite a bit more research than existed, 7 or 10 years ago. And in other ways, there's less. We've actually seen an almost complete drying up of basic research. Basic science research is dead in the United States. The journals are almost pure marketing spin. And this happened in 1992 with the creation of something called evidence-based medicine, where the journals are not being written for the doctors or the public. They're being written for the courts. And they're written for the challenge of something called the Daubert standard. So in a product liability case, a judge will then have to respond to a pharmaceutical company's set of attorneys who say, look we've got 200 articles right here that say Prozac causes neurogenesis and helps people heal from stroke. And so the journals are just for the courtrooms and just for marketing hype. Real science, real basic science of the kind that I've presented here, like those animal studies, and then trying to look at, hey, case reports, here's what's happening in our patients, or these prospective reports that are not drug company funded. Those are the real deal, where real curious clinicians are asking the question, hey, what's happening to real people? And so I haven't, none of this information is available in textbooks. None of this is the stuff that they're going to be teaching doctors in their training programs, because we don't have a medical industry that's focused on health. We have a medical industry that's focused on chronic illness and not helping people really recover. We want people to stay chronically sick so they will keep taking the treatments that help the stock market. So ultimately, this is a political economic battle as much as anything else. That if we transform the culture of our country, it's not just psychiatry that is having this problem. It's multiple areas.
One last question.
I was wondering that you said that these antidepressants specifically penetrate into the cell wall and go inside the brain neurons. Can they also go inside other nerve cells such as the spinal cord and peripheral nerves and wreak havoc and cause perhaps chronic pain or some other type of problem?
Wow. Well, first of all, I didn't say that here, but it was a great comment because you're right. There is a phenomenon that doctors know nothing about. There's a lot of things we know nothing about. That's not new. But there is something that the toxicology community knows about, which I wrote about in my dementia book, called drug-induced phospholipidosis, DIPL. I know, if you say it fast enough, it sounds like it's California fragilistic expialidocious. This is actually called drug-induced phospholipidosis. Anyway, what happens is that some chemicals are, whoops, I get excited about that. They're called amphiphilic, which means they're both water-loving and they're fat-loving. So basically, an amphiphilic molecule is something that can kind of sneak through things, and it can enter membranes and it can enter cells. So your question's a very intelligent question, which the medical profession really doesn't pay attention to. The pharmaceutical industry has to pay attention to this because before a new chemical can come on the market, it actually has to be tested for this property. And so why is this important? Not all the medicines that are prescribed in medicine just hit the surface of the cell and then fall off. Some of them actually are entering the cells. And when they enter the cells, they get taken up into these little storage bags, like a Ziploc, that are called liposomes. And so those, lysosomes. And so those lysosomes begin to store the drugs. And if you look at these cells under a microscope, they look like little onions, like onion skin, lamellated. They're called lamellated bodies. And these demonstrate collections of these kinds of drugs. Well, this happens with numerous antidepressants. And many other medicines, hydroxychloroquine, which is Plaquenil, given for malaria, amiodarone, which is an antiarrhythmic that causes cardiac muscle enlargement, cardiomyopathy. Plaquenil causes a retinal toxicity and neuropathy. And so, in my opinion, one of the great fascinating questions is how do you connect the cellular accumulation of these chemicals in different organs of the body, and at what point does the medical profession say, hold it, enough is enough, we can't have that. So this phenomenon does go on with numerous medicines that are on the market because they were older drugs. So you're absolutely correct. A lot of these medicines that doctors are thinking they're just binding the surface and going away are actually going inside cells. And we really don't know enough about the toxic consequences, but neuropathy is certainly one of them. And potentially, some of the dementia effects of the medicines may well reflect that phenomenon as well. So it's called DIPL, drug-induced phospholipidosis. Probably no doctors talk about this at all, but it's probably it's a very, very important phenomenon. Great question.
Okay, thank you, Dr. Jackson.
Okay. Thank you.